Right. Hello, everyone. I'm glad. Thank you very much for the people joining at 5:30. Hopefully you had a good day at work. So I'm Hoda Albouz. I'm a clinical oncologist in Bristol. And for those who haven't been to this meeting before, because I think some of you haven't joined this meeting before. So this is a forum, clinical oncology forum, that we aim to discuss gynae cases, usually radiotherapy or brachytherapy, but actually now with all the systemic treatments that are coming up, we're open to all of this. So this is number 8 that we have done, and it's done quarterly. I'm joined by the lovely committee, Alex Taylor, consultant clinical oncologist at the Royal Marsden, Louise Hanna from Velindre, Shaima from Nottingham, and this time we're actually also joined by Asma, who is now the clinical oncology, the UK clinical oncology representative for the BGCS, having taken that over from me. So welcome all of you. In this forum, we normally meet up quarterly as virtual, as we do. However, there is a move now that we try and join the BGCS conference once a year so that we can all meet up in person. And that would be great if you can all come and attend. The first one will be this year, will be, sorry, next year. It'll be in Bristol in June. And it will be on vaginal cancer, and we'll be inviting some GCS representatives as well to have an exciting discussion. So please stay tuned and register. So anyway, I think we've got a few people in. We're expecting there is a lot to have registered, so we're still waiting for a lot of you to join in. But I think we will start anyway. If I can just ask all of you to mute your microphones, please. So only those who are speaking that will be turning on their microphones. However, this is not a very usual, it's not a webinar. It's not sort of a very usual virtual meeting. We like it to be as interactive as possible. We would love to have you feeling that you're actually around a table and we're all sat in the same room. So if you do want to have any question, you want to ask any questions, just raise a hand by the raise hand icon, and then we will tell you to speak and you can unmute your microphone and talk. Those who are not feeling comfortable to do that and want to put a question in the Q&A, Shaima will be keeping an eye on that and will tell us what the questions is. But I'd love it that you actually will keep your cameras on and chat to us and ask questions so that we can all get the most out of it. Okay. You will get a certificate of attendance at the end of this. However, you will need to just tell us your feedback about it first so that we can send you the certificate of attendance. So, right, I think we will start now. The numbers are keep increasing, so we'll start now. Susie Masson is my colleague. She's a clinical oncologist in Bristol, works with me, and she has got a case that she's going to present today, talking about the systemic treatment for endometrial cancer, which I think all of us had a lot of questions with the forums that we've been to and the questions around the country with Ask a Friend, what would you do? So here is my friend. So go ahead, Susie.
Thanks, Hoda. I'll just share my slides. Hang on a second. If I try and... Can you see the slides okay? I don't...
We can see the slides, but it's not in the presenter mode.
No, I don't know how... sorry, hold on a moment.
No, it's all right.
Let me just share my screen, and that's probably better.
Probably that one. Then if you put it on, yeah.
There we are. Hopefully
great, yeah.
that's better.
Yeah.
Hi, so yeah, as Hoda said, I'm Susie Masson. I'm a consultant clinical oncologist also in Bristol. So I'm just presenting a case that we've had this year, and then the discussion will follow. So this is a 62-year-old lady who presented with postmenopausal bleeding back in May 2025. She was initially investigated with an endometrial Pipelle sample, which was non-diagnostic, but went on to have hysteroscopy and endometrial polyp removal in mid-June. This demonstrated a high-grade endometrial cancer. A high-grade endometrial cancer, which was molecularly typed and was found to be P53 null type, so P53 mutated, MMR proficient, ER positive, and a poly was done which showed no variants of clinical significance, and the final diagnosis from the biopsy was a high-grade serous endometrial cancer. She has a past medical history of breast cancer about 18 years ago, which was managed with mastectomy, adjuvant chemotherapy and tamoxifen, but otherwise no major comorbidities, and she has an obese BMI. She went on to have a staging CT scan following the diagnosis. There's a couple of shots from it here, but essentially it showed advanced disease. So appearances in keeping with high-grade serous endometrial cancer with widespread peritoneal disease and small volume ascites. There was no disease above the diaphragm, but by virtue of the peritoneal disease, she's FIGO stage 4B. So the first poll, I don't know if you're able to put that up, Hodder. So this is just at this point, what would your MDT recommend in this case? So I've put the options as palliative chemotherapy, chemotherapy with debulking surgery as per the sort of ovarian cancer pathway, palliative chemo and immunotherapy, or chemo, immunotherapy and debulking surgery. I can't see the poll, Hodder, without stopping sharing, so I don't know if you're able to comment on answers. So I've just stopped sharing so that I can see the responses. So we've got the sort of quite a big split, but some people, so about 60% would go for a sort of chemo systemic therapy and debulking approach, and the majority of the rest chemo immunotherapy. Okay, so I will go back to sharing. So we had our initial MDT discussion about this lady who was in mid-July, and as we said, stage 4B endometrial high-grade serous cancer, P53 mutated, MMR proficient. The MDT recommendation was at that point for primary chemotherapy with a view to debulking surgery after 3 cycles with restaging imaging at that point, as per high-grade serous fallopian tube or ovarian cancer. She had an oncology appointment that same day and accepted the recommendation for chemotherapy. At that point, she had a post-biopsy endometritis and was on antibiotics. So the one of our registrars who saw her at that appointment arranged for a further review a couple of weeks later to ensure that the infection had settled before starting chemotherapy. But essentially, we'd made the plan to go ahead with chemo. She then came back for that review on the 6th of August, where the infective symptoms had resolved. So the plan then was to proceed with chemotherapy, and that was due to start the following week. On the same day, 6th of August, we received notification that NICE had approved first-line pembrolizumab in combination with chemotherapy for endometrial cancer. And that, as many of you will be aware, is now recommended as an option for untreated primary, advanced or recurrent endometrial cancer in adults. And the recommendation is that carboplatin paclitaxel is given alongside pembrolizumab, and then that the pembrolizumab can continue for up to 2 years in total as a maintenance treatment. This is just from the CDF criteria, but the patient meets the criteria in that at this stage she's not a candidate for potentially curative treatment. So although there is a plan to consider surgery, that's not felt to be feasible at this point in the pathway. So we were actually contacted by the patient very shortly after that appointment on the 6th of August to say that both herself and her next of kin were become aware of this NICE recommendation, and they requested an additional discussion with us about whether she could have this treatment in addition to her chemotherapy. So we saw her again just before she started chemo and had a discussion about the addition of immunotherapy, which she was very keen to take up. So she consented for the pembrolizumab and then commenced treatment 8 days after the publication of the NICE recommendation. The update now is that generally, so she's now had 4 cycles of chemotherapy. In terms of the chemo, she's tolerated it very well. She's had some asymptomatic hypomagnesemia and low potassium, which has been corrected. We've not seen any endocrine toxicity clinically or on her blood tests, and she hasn't had any specific immunotherapy toxicity that we can identify. So a fairly typical sort of chemo pathway, really. She had sorry, I missed out a slide. She had a CT scan after 3 cycles, which has shown a partial response to treatment. She still has quite extensive peritoneal disease, but the surgeons have said that if they were to operate at this point, she would need colorectal input. But so in this context, the second poll, if you're able to put that up, is so in the context of somebody who's had chemo immunotherapy 3 cycles with a partial response, and surgeons feel that surgery may be feasible at this point. What would your MDT recommend at this stage? Would it be just continuing with systemic treatment, pausing the systemic treatment and proceeding with surgery, continuing the systemic treatments for a further 3 cycles of chemo, and then reassessing to consider surgery at that point, or any other approach? So sorry, I'm just going to stop sharing again for a second. Let's give people a second to reply. So
Sorry,
yeah,
I'm back.
That's okay. So that's interesting, actually. So almost half of people would continue with the chemo at this point and re-image after 6 cycles, with a view to surgery at that point. Some people would just continue with the treatment and not plan for surgery, and then a small number would plan for surgery at this point. So actually our MDT, so our surgeons planned to see the patient in the surgical clinic after that CT. They have discussed with her the option of interval debulking surgery with colorectal input, and following that discussion, plan was made to schedule a date for surgery after cycle 4 of chemotherapy. Basically, she was just about to have her 4th cycle, and a surgical date was not going to be available until sometime in the future. So the pragmatic decision was to give cycle 4, but then plan for surgery and pausing chemo at that point. She then, just last week, following her 4th cycle of chemotherapy with Pembro, had an ED attendance with essentially found to have large pulmonary emboli, acute PEs. So she's been anticoagulated. So essentially at the moment, the plan is likely that we will just be continuing with the chemoimmunotherapy and then reassessing after the 6th cycle in view of the acute PE. So my sort of summary from this is that this is our first patient that we've treated with pembrolizumab for the new indication for immunotherapy in pMMR advanced endometrial cancers. So I know there is discussion to be had about the pros and cons of first-line treatment in this group. We, in this case, haven't seen any unexpected immunotherapy toxicity. Arguably, the side effects that we've seen are most likely to have just been from the chemotherapy. So n=1, we haven't so far seen anything unexpected. And then there's a sort of wider question about what the role of surgery is in this patient group, and whether what the variation in practice is surgically with advanced endometrial cancers, and whether we have any concerns that immunotherapy affects this in any way. So that's the end of the case presentation. Do you want me to carry on sharing the slides, Louise?
I think Asma's going next.
Okay.
If you could carry on sharing them for my bit, but I don't know if Asma's got her own slides.
Yeah, I've got my own slides.
That's fine. I'll stop sharing them. That's fine.
So Louise and I are going to be doing a discussion on which treatment we should be opting for these patients, and we're going to give you a view from either side, and then we're going to repeat the poll again. So I'm hoping you can see my slides there.
We can, but they're not on the presenters mode. Yeah, that's better. Thank you.
So I'm presenting on giving immunotherapy should be given upfront as per the NICE guidance. So just to recap the history, so it's a 62-year-old lady with a high-grade serous endometrial carcinoma, P53 mutated, MMRP, ER positive, poly wild type. Imaging shows that all of her disease is subdiaphragmatic with peritoneal ascites, and she's performance status 0 to 1, I'm assuming from what I can see from Susie's case, and she had no significant comorbidities. So the idea of pembrolizumab in these patients is pembrolizumab has got widespread use in other tumor types. So we know it's well used in metastatic non-small cell lung cancer and, for example, recurrent or metastatic head and neck small cell cancers as well. And in both cases gives an overall survival benefit. So NICE approved this treatment for our patients, as Susie said, on the 6th of August, and it's now allowed for us to be using this in the primary advanced or recurrent setting, and we can give it alongside carbotaxol, and for a duration of 2 years, we can continue the pembrolizumab for as long as patients don't have disease progression or unacceptable toxicity. And this is a CDF criteria, and as Susie has highlighted, that this is either patients who've got stage 3 disease, or stage 4, but either way, as long as they don't have potentially curative treatment with either surgery, radiotherapy, or chemoradiotherapy. So the basis for this change in guidance from NICE is based on the Keynote 868 study, which is a phase 3 double-blind placebo-controlled multi-center RCT, which was run in the USA, Canada, Japan, and South Korea. And 810 patients were enrolled in this in total, and these were stage 3 to 4A with measurable disease, or stage 4B with recurrent disease, and that's with or without measurable disease. They were allowed to have prior adjuvant chemotherapy as long as the treatment-free interval was more than 12 months, and exclusions were the usual, but carcinosarcomas were excluded from this. And the results were stratified by MMR status and performance status, and then prior adjuvant chemo status as well. Just a reminder of the arms in this trial. So there was the Pembro and chemo arm, which was Pembro 200 milligrams every 3 weeks with carbo AUC5 and paclitaxel 175 milligrams per meter square for 6 cycles. And then the Pembro continued at 400 milligrams every 6 weeks for up to 14 cycles. And then the placebo arm was just replacing the Pembro with placebo, and that also continued up to 14 cycles afterwards. The primary endpoint here was progression-free survival, with secondary endpoints being overall survival response rates, and then subgroup analysis on MMR and PD-L1 status. So this is just to show you the number of patients who enrolled. So it started off with just over 1,000 patients, and 816 remained in the trial. About a quarter of those were DMMR, and 3/4 were PMMR, and then they were split almost equally between placebo or receiving the Pembro. This is to compare the baseline characteristics, and I've just highlighted here that in the PMMR cohort, there were a higher proportion of Black patients, and this reflects actually on the next slide that I'll show you the subgroup of the histological subgroup of high-grade serous and more high-grade cancers were in the PMMR group. So you can see here on the remainder of that table that in the PMMR group, you had a quarter of them, 25% of them were high-grade serous, 50% being then between endometrioid grade 1 to 3, whereas in the DMMR group, very few, only 2% were high-grade serous, and then around 80% were endometrioid. And then in terms of prior treatment, in the PMMR group, a quarter of those patients received prior chemotherapy. And in terms of radiotherapy, they were quite well matched. So this is a Kaplan-Meier curve showing the progression-free survival in the DMMR cohort. And you can see it's a very significant result there. But we're more concerned about the PMMR group because that's what relates to our patients. So this is the PMMR group, and as you can see, again, a significant result, hazard ratio of 0.54, and median progression-free survival in the intervention arm of 13.1 months and in the placebo arm of 8.7 months. And what's interesting in this graph is the graphs actually, the lines start to separate quite early on, and you do tend to get you get this plateau here. The data is still immature, there's still more to come, but you can see that the graphs are diverging quite early on with this plateau. So just to summarize the adverse events in these groups, so almost all patients experienced at least one adverse event of any grade, and they split it between DMMR and PMMR as well, and you can see it versus Pembro versus placebo. So almost everyone experienced some form of side effect. Grade 3 side effects, grade 3 or above adverse events, were more frequent in the Pembro and chemo arm, and here again comparison between DMMR and PMMR, but in the PMMR group you can see about a 10% difference, more frequent grade 3 adverse events in the PMMR group. And then in terms of fatal events, they were uncommon, but in the PMMR cohort, around 8 patients experienced a grade 5 event, and 6 of those were in the pembro arm and 2 of those were in the placebo arm. So that was the data that was released in 2023, and there was an update in 2025 where they were looking at overall survival and then the exploratory analysis as well. And in this, we can see that the progression-free survival favoured pembrolizumab in both dMMR and pMMR, both significant results. However, the overall survival, the data is still immature, but there is a trend in favour of pembrolizumab, and that's in both arms. But the most important thing was that there were no new safety concerns, as pharma like to put it. So an update on our patient, if we relate this back to our patient, she was a high-grade serous patient. She was MMRP, so she fits quite nicely into that cohort. We can see that the PFS gain that she's going to get with chemo IO, the median PFS gain is 13.1 months versus 8.7, and the curve plateaus early, and it appears to be a longer response. So the data is still immature, so we're still yet to see if there's going to be these long-term responders there, which is what it looks like. And when we compare that to PEM-LEM, which Louise is going to present the data on that, the median progression-free survival there is 6.6 months versus 3.8 months. And then if you look at the curves, they continue to drop off. And I've just got them there to show you. So that's the PEM-LEM data versus the carbotaxel pembro. So you can see that the curve just is continuing to drop off there, whereas with pembro, it does plateau. There's also a better side effect profile with upfront chemo IO. So the frequency of grade 3 or above toxicity in the pMMR group was 55% versus 45% in the placebo group, whereas when you compare that to PEM-LEM, grade 3 or above was 88.9% versus 72.7% in the chemo arm. And we know from our own experience how patients struggle with the combination of PEM-LEM. But then you may ask, well, how does this fit in with surgery? With chemo and IO, how does that all fit together? So I did a bit of a literature search, and this is pretty much about all that's out there in terms of neoadjuvant chemotherapy for these patients. There were 2 systematic reviews and 1 meta-analysis, and then the rest of the data was pretty much multi or single institution retrospective cohorts or case reports. And this is the most recent systematic review, which was published in 2024. And they whittled down the papers down to 9 papers. But as you can see, they were all retrospective, either mono-center, majority of them, and some multi-center cohort data there. So neoadjuvant chemotherapy, or let's start with chemotherapy. There's paucity of data there. Most of the data is retrospective or case series, and the results are very heterogeneous. But what we can see from this limited data, that the overall survival is similar to upfront surgery. The perioperative morbidity is generally lower than extensive cytoreductive surgery upfront, and overall the results look encouraging. But surgery after IO, now there's no data from IO studies in endometrial cancer regarding subsequent surgery. It wasn't part of the Keynote 868 protocol. So it's difficult to comment on that. However, there is data from other tumour types. Now, currently, ESGO, BGCS, NCCN and ESMO, in general, they recommend upfront cytoreductive surgery where feasible. However, IDS can be considered if a chemotherapy response is seen, and this is if you give a protocol similar to how we would give in ovarian or fallopian tube cancers, and it's considered for selective patients, so those that would be poor candidates for upfront surgery. And I think in this case, this lady had there was a question of whether she would need an exentrative surgery or bowel surgery to get clearance. So there is some data from other cancers. So bowel cancer, for example, there's some retrospective studies in rectal cancer suggesting that there's no difference when we give IO in addition with chemoradiotherapy, and as well as dual agent immunotherapy, so Ipi-Nivo, for example, in the DMMR colon cancer cohort. And actually, what some of the data from the DMMR bowel cancer cohort shows that many patients never even proceeded to standard surgery because of a clinical complete response. Now, I know that's the DMMR cohort, but that's a promising sign. The small number of patients who did proceed to surgery, there was no signal of excess surgical morbidity, but the numbers were small. We have to acknowledge that. So overall, I think from the data from other tumour sites, there's no signal of an increased surgical complication rate, but further studies are needed on that. And there are some ongoing trials as well. So there's currently planned or in the pipeline dostarlimab neoadjuvantly in the MMRD patients. So in our patient, giving IO neoadjuvant, I didn't feel it would compromise her surgery based on other tumor type subtype experience, and she would still have the option for cytoreductive surgery as per the guidelines that have been recommended. So I think in conclusion, as she's a high-grade serous patient, she fits quite nicely in that cohort to have upfront chemo IO. I think she would benefit from a longer progression-free survival compared to PEMLEM in the second-line setting. I think there's a better side effect profile for upfront chemo IO, and I don't think it would compromise planned surgery as well. So that option for cytoreductive surgery remains. And then you may ask what options would she then have second line? So I think in these patients, as you can see, that Kaplan-Meier curve started to plateau. So these patients, there may be some long-term survivors in these patients, which we're not seeing with the PEMLEM data. But if second-line options are needed, there's emerging trials with ADCs and HER2, so other options are coming. But I don't think we should limit our use of IO chemo because of that. So in conclusions, that immunotherapy should be given up front as per NICE guidelines. Let Louise now do the counter argument.
Thank you very much. Thanks, Asma. Louise, please.
Thank you very much.
Thank you. Thanks, Louise.
Thank you. Are you able to share the slides, please?
Yeah, hold on a second.
It was from slide
yes.
29.
Yeah, so that's where I stop. So this, no, I can't see which slide I'm on. Hold on a second. Just one moment.
Is it the next one?
Yeah, I'll just go to slide 29.
Sorry.
That's okay. Hang on, just 1 second.
So while Susie's getting, okay, I think it's the next. Just keep going down. There we are. There we are. Yeah.
There we
Okay.
are. Sorry.
Thanks so much. So I've been tasked with presenting the counter argument, which is that immunotherapy should be given as second-line treatment as per NICE guidance. So NICE guidance has said that pembrolizumab and lenvatinib are indicated in patients who progressed on or after platinum-based chemotherapy, and if they cannot have curative treatment such as surgery. So obviously this NICE guidance came out before the more recent one, which recommends upfront treatment. and it was based on the Keynote 775 study. And this randomized 827 patients who had advanced or metastatic endometrial cancer or carcinoma after platinum-based chemotherapy. Now, you were allowed to have 2 lines of chemotherapy if the first one was adjuvant. So basically, the patients were randomized between lenvatinib plus pembrolizumab versus the physician's choice of chemotherapy, which did not include carboplatin. So the physician's choice could be either doxorubicin or paclitaxel. And the patients were stratified by the MMR status. They needed to be ECOG score 0 or 1 and had prior therapy. And thanks to Susie for preparing these slides, very grateful for that. So just talking about the demographics, so the patients were well sort of balanced. The median age was 64 or 65 in the len-pem versus the chemotherapy arms. In terms of ethnicity or race, there were 17 or 14 patients who were Black, and 85 versus 92 who were Asian, and 261 versus 246 who were white. So they were well balanced. In terms of the MMR status, so 84.2% of patients in the len-pem arm versus the chemotherapy arm of 84.4% were pMMR, whereas around about between 15.5–16% were dMMR. ECOG status was about sort of 2/3 0 and 1/3 to 4/10 or 2/5 performance status 1. And the patients were well balanced for previous radiation. Most of the patients had endometrial carcinoma, which was high grade or low grade or not specified. 25% had serous carcinoma, and in the len-pem, and 27.6 had serous carcinoma in the chemotherapy arm. So about a quarter had serous carcinoma. Obviously, the patient presented here had serous carcinoma, and smaller numbers had clear cell or mixed. So in terms of the overall survival there, I think you can see on those, so there was a significant difference between the 2 arms with the median progression-free survival and the overall survival. So the hazard ratio for progression or death in the pMMR group was 0.6, and that was highly statistically significant. And for all patients, it was 0.56. And then for overall survival, the hazard ratio in the pMMR population was 0.68, again, highly significant. And all patients, it was 0.62. So you can see that there you've got progression-free survival was 6.6 months in the pMMR group, and 10.7 months in the dMMR group, overall 7.2 months, and the overall survival was 17.4 months in the pMMR group, 28 in the dMMR, and overall 18.3 months. So that overall survival figure, that reflects the fact that most of the patients were pMMR. And you've got the overall response rate there. And so you can see the comparison there with the control group. So it's highly significant. Response rate was more than doubled, and the progression-free survival was very, very different there. You can see those. So there was greater overall survival, progression-free survival benefit in both populations. This obviously was a a real game changer in terms of immunotherapy becoming available for the whole population. The greatest benefit did seem to be in dMMR, but these were small numbers, but there was a clinically meaningful response in pMMR patients where single agent immunotherapy is largely inactive. So in terms of the safety profile, most of the patients did have some form of toxicity. So almost all the patients in the two treatment groups did have adverse events. The most common event being hypertension in the lenvatinib and pembrolizumab, and in chemotherapy, the most common toxicity was anemia. There were grade 3 or higher events in 88.9% of patients receiving len-pem and in 72.7% of those receiving chemotherapy. So the len-pem was a little bit more toxic than the chemotherapy. So basically, why should we wait to give the immunotherapy in these patients? And I think the argument for waiting really is that we've got a lack of information of immunotherapy up front with surgery. So we've got a lack of data on that. So the combination of immunotherapy, chemotherapy, and surgery is not really fully studied. And the other argument as well is that if you're giving immunotherapy up front, then you are not being able to access the lenvatinib. And we do know that lenvatinib does have some response, some benefit in single agent as a single agent treatment. So presumably it is contributing something here in this case. So I think it's, obviously with a lack of data, it's very difficult to be certain. I mean, the other option is the other argument against giving immunotherapy up front is that you have got the option at the point of relapse, so you're not denying that patient immunotherapy. And the other thing is that some patients do have a durable response if you can get down to sort of 0 centimeters or optimal debulking with surgery. Then some patients do have a durable response, and so it's a lot to put patients through with 2 years of immunotherapy, where some of those patients are going to do fairly well anyway. So that's the argument against, and very happy to open the floor for comments.
Thank you very much, Louise and Asma and Susie for this.
Thank you. Yeah, thank you very much for the slides,
I think
Susie.
it is an ongoing debate, which we all wonder, and as with everything, being new, we've all had some critical thinking, I must say, about it. So does anyone have any questions? I can't see any raised hands. Mark, you've got your hand up, so if you don't mind, yeah, carry on.
Hello. Does anyone know a stage breakdown for the Keynote 868 people? Because it says you can have node-positive disease that's visible, or you can have metastatic disease, and I think they're different entities. We've had a strong debate in our department as to whether someone should have immuno because they've got paraortic nodes, whereas we've been quite happy to treat them with induction chemo followed by consolidation radiotherapy. And I would say we have cured people in that situation, and we haven't kept them on treatment for 2 years and spent a king's ransom. So if you've got genuine metastatic disease, absolutely for it. We haven't got anything that's very good. But if you're nodal disease, some of these people can be cured with radiotherapy, and the paper is just full of whether they're Spanish speaking, Black or Inuit, but nothing about stage. Does anyone know?
Mark,
So
there's
who would
nothing,
like
there's
to
nothing
answer?
about that in the paper, and in the second publication in 2025, there's nothing about that either. I did see something in the when I was reading the actual NICE guidance that they've not released any data on the PDL1 status yet. So I wonder whether they're also keeping hold of the stage as well for the moment. But I certainly didn't find anything when I was doing my reading.
We had to look. We had a violent, well, not violent, but a strong argument in our MDT.
I'd like to see how violent that went. Okay. Lovely. Rima, before I take your question, I'm just going to ask you all to do after the debate, if because Debbie kindly has put the poll back on, and then we'll take Rima's question. So that's the first poll that what would you recommend, and that's after the for the patient that Susie presented. So if you all answer the poll, please. Lovely. Okay. So I think that, it definitely with immunotherapy, this is what I can see, but also it's equal between having IDS or not having IDS. Okay. Can I take Rima's question? Oh, actually, let's do this poll again as well. And that's after having had the mid-treatment CT. I mean, I guess that's not really debated with or addressed with the debate, but I don't think that would change much. But then it would tell us whether, what your feeling is about the surgery. Okay, so the majority would do the surgery after 6 cycles. I know it wasn't our intention here, but the patient guided us to that with her PEs. Okay, Rima, can we take your question, please?
Thank you. Thanks. I had a question and a comment, actually. My question was, I find it really difficult with these patients, whether you label them as neoadjuvant or palliative, especially when it looks like it's something, not miliary peritoneal disease, but something that might potentially be resectable, even though you've labeled it as stage 4 because of being extrapelvic disease. So I wasn't sure if you're applying for CDF funding. I can't remember the questions on the CDF form now, whether there is a question of, is this locally advanced, is this palliative treatment, or if you label it as neoadjuvant treatment with a view to potentially debulking after 3 or 6 cycles, can you still, in good faith, fill in the CDF form, was my question. And the comment really is, I think we need to take a step back, as you've rightly shown with your literature review, that, we're all extrapolating from the experience in ovarian cancer, and we're treating these patients with this sort of neoadjuvant approach. And I've actually been trying to get an audit going with our patients in Kent, because we've adopted this approach quite a lot before the advent of immunotherapy, doing this sort of completely following the ovarian paradigm and doing the neoadjuvant CT after 3 cycles, CT after 6 cycles, operate. And then, of course, the thorny question of whether you give radiotherapy or not, depending on how much residual disease there was and so on. And I don't know if there'll ever be a randomized trial. And now with before we move on to using this neoadjuvant immunotherapy, I wondered if there was we could make a case for a multi-center retrospective review of this, because between us, we must have done thousands of patients over the years. I'm actually retiring from clinical practice in 2 months, by the way. I was hoping to come and say goodbye to everyone at the UK GOM, but unfortunately I can't make it. So I'll take this opportunity to say bye as well to people.
Wow,
But
okay.
just a thought. Thank you.
Good luck. Right. So Alex, is your hand up to comment on Rima's? Lovely. Okay, well that's brilliant. Okay.
Just, yeah, I mean, we can discuss lots of things here, but to the specific point, Rema, that you were raising about neoadjuvant or palliative, or the terminology, it's just to clarify the ESGO guidance, because I was part of that. And you'll see the wording in the ESGO estro is primary chemotherapy. It is not neoadjuvant. And I think we avoid palliative these days, if you're thinking. But it was very specifically, the onus is not that this is ovarian cancer, but that it's primary chemotherapy, but surgery is considered if you are going to achieve complete debulking. So it is not saying this is to be treated the same as ovarian cancer. And there was a lot of discussion about the terminology, and that's why I think it ended up being primary chemo, because it was not saying this is definitely going on to surgery. But I thought I'd clarify that. We can, I mean, there's lots of comment we can have the case, because I suppose what we haven't discussed is, should we be giving them PARP inhibitors, these patients with P53 tumours, because that may imminently come through NICE. And I might throw up in a minute when we do some slides. How do, I mean, I maybe put it back to asthma, because you were arguing for the immunotherapy. How do you explain the difference between this and the B21 results, which was adjuvant chemo and pembro, which showed a detriment in the arm, well, non-significant, but detriment to adding immunotherapy in the adjuvant setting for high-risk patients?
Yeah, that's a difficult one to argue, isn't it, to Alex? But I can't remember what the subtypes were in those patients. I can't remember. I don't remember offhand what the division of the subtypes were within that patient group. But I mean, I think this data is immature yet. You know, we still haven't got the overall full overall survival data on it. So I think we do have to keep that in mind as well. And certainly our practice at UCLH, we're quite selective in the patients that we are giving immunotherapy, this chemo IO combo. We are at the moment just giving it for the P53 mutant patients. We feel that that's where the greatest benefit is going to be. But yeah, I think it's difficult to argue. But I think we've still got data awaited on this, so I'm still, you know, I'm certainly not giving this blanket out to all of my patients. At the moment, I'm just restricting it to the P53 mutant patients.
I think that's
and then obviously
sensible.
It's a reminder that the trial is also open for these patients to add in sacituzumab in randomization as well. So again, we've got so many options for these patients. So. I don't know the answer. It's a similar thing, I think, with every patient. You see how fit they are in the scenarios. Yeah.
Okay, I will take a final question and then we'll ask Robin to present his case. Siddharth.
Thanks, Laura. It's just a couple of comments. One, Alex, that you mentioned regarding adjuvant versus neoadjuvant immunotherapy, no difference. I think we saw a similar result in breast cancer. In neoadjuvant, it makes a difference. In adjuvant, doesn't. Nobody knows why. So I think that's the real thing, but I'm not sure why. The second thing is regarding carcinosarcoma. Interestingly, the keynote study excluded carcinoma, but CDF does allow carcinosarcoma for pembrolizumab. So I think that might be the case if you have carcinosarcoma, which is MMR proficient mostly, then probably better get on with the carbotaxol and pembro as a first line, because you won't get a second chance to give pembro to those patients, because the pembro and lenvatinib excluded, CDF excludes carcinosarcoma.
That is a very good point, actually, and thanks for highlighting that. I totally agree. Lovely. Louise, final. So,
sorry, yes.
That's all right.
Yeah, just hearing the discussion really, it does make you certainly make
Sorry, you're on mute.
I'm so sorry. Yeah, no, just hearing the discussions does make you reflect that, you know, so many different options. Life's a lot more complicated than it used to be. We had very few options that we could offer to patients, and I think, you know, I think it's really interesting what, you know, what sort of factors make patients decide to opt for particular things. You know, choices are much more relevant now, and patients, you know, they have a lot more to deal with in terms of making decisions about what they want. And there is the GRACE, not to do with immunotherapy, but there's a GRACE study at the moment looking at, you know, how do people decide with regard to radiotherapy. So that's something that's going on at the moment. But it's a really interesting question, really, is how do we explain these things to patients, and how do we support them in their decision making?
Thank you very much. In the matter of time, I know it's an endless discussion, but you're right, Louise. I think the choices are a lot, and the patients do deserve to be supported through that. And it's, as usual, it's case by case. Yeah, lovely. Okay, so Robin. Robin Eames is our clinical oncology registrar. He's now going to present a complex case for this meeting, and then we'll also please keep an eye on the polls for any questions, and then we'll open the floor again for questions and discussions.
Right, I'm trying. Am I sharing? Yes.
You are sharing. Just put it on a presenter mode.
Presenter mode. Slideshow. There we go.
Yeah, perfect. Lovely.
Perfect. Now I can't see anything. Oh no, I can. Yes, I can see stuff now. So this was a complex case that I've been written up. So it was a 60-year-old patient who, in April of this year, had a diagnosis of adenocarcinoma of her uterine cervix. She was stage 4B, PD-L1 positive with a CPS of 1 to 2. But a PET scan done at that time demonstrated some avid uptake in a cervical tumor as well as a mental disease. We'll come back to this, but the uterine cervical cancer later got downstage to 2B, and I'll explain why shortly. So she was seen in clinic in that month, and a decision made to have chemotherapy with carboplatin and paclitaxel alongside bevacizumab and pembrolizumab, for 6 cycles, with a plan to continue on pembrolizumab as maintenance treatment. But because the mental disease looked a bit odd, she went on to have an mental biopsy, and that showed high-grade serous carcinoma of a Müllerian tract origin, so a completely separate primary. It was found to be in the right fallopian tube when she went on to have later treatment, but that was staged as a 3C. So she started treatment before we got this biopsy result, and so she was started on treatment for cervical cancer in the initial phase. So the question is, do you continue with cervical cancer style treatment, or do you switch treatment because you've now got this Müllerian tract treatment? And I think there's a poll that comes up now. So I think it looks like,
so the majority said to switch.
Yeah, which is what we did. Oh, what? There we go. Oh no. Back. I've gone too far. Slide. Sorry. So yes. So this shouldn't say questions, issues. So the pembrolizumab was stopped after cycle 1, as it's not indicated for Müllerian subtype, but we continued on with the bevacizumab and chemotherapy. She had a repeat review in the MDT, and had restaging scans after 3 cycles that show a good response to chemotherapy with no measurable disease now in the pelvis and minimal disease in the upper abdomen, and a right liver lobe small amount of disease on the surface. So the question is, what do we do at this point from a surgical point of view? Do we offer radical hysterectomy, or so with debulking, or simple hysterectomy?
Lovely. 100% said radical hysterectomy.
Radical. Excellent. So that is what we did. So she went on to have interval cytoreductive surgery with no macroscopic disease and a good chemo response score. This is where we were able to find out that the high-grade serous carcinoma was originating from the right fallopian tube, involving the right ovary and showing lymphovascular space invasion. It then also confirmed the synchronous HPV-associated adenocarcinoma of the cervix, as stated on the histopathology report on screen. Actually, the omentum and small bowel mesentery had a really good response with fibrosis and inflammation only, so that's where the good chemo response score. So she was seen again in clinic in July with a plan to restart chemotherapy for a further 3 cycles, and then considering adding in bevacizumab from cycle 5 to give enough time for post-op recovery. However, while that was all going on, her post-operative recovery was complicated by a C. diff infection, which actually was found after she had her cycle 4 post-op chemotherapy, and that was in August. So she had 3 to 4 weeks off treatment after that point because of being quite unwell post-surgery. So her cycle 5 was delayed, 2 weeks, not 3 weeks, due to the significant C. diff colitis. And actually there was a question in one point whether it was toxic megacolon. She was then reviewed again in the September prior to cycle 5, with symptoms improving and a plan to proceed with adjuvant treatment. I suppose the question we had at this point was, do we, given the bowel effects that PARP and bevacizumab can have, do we add that in, yes or no, was our question. A bit more split there.
Yes.
So
I don't know if the rest have seen that it's 67% said yes to add PARP inhibitor. I'm not sure how much you can see in there.
I can't see very much.
Okay.
So we didn't add the bevacizumab because of the colitis, and then we went on to discuss whether to give her any post-op radiotherapy, and if so, what do we give with post-op radiotherapy, and do we give nothing? Do we give external beam radiotherapy, pelvic radiotherapy with brachytherapy, or do we give brachytherapy only?
So can I just confirm that this was a positive margin?
Let me get the margin back.
Sorry, because you just said there was, because there was vaginal biopsy was positive.
Yeah.
Yeah, so there's the histopathology report there. So it covered the posterior cervix of this yes, so there was a positive margin because they did do a vaginal biopsy. So there was stuff in the, yes, sorry, is what I'm trying to say.
So 100% say brachy only.
No, Hodder, I think it's the opposite.
It's the opposite. Most people say
sorry. I think mine had just the lag in there. Sorry, yeah.
So actually, in the end, we went on discussion with the patient. We decided not to give the pelvic radiotherapy and just to have the vaginal vault brachytherapy.
Yes, that's right.
And that is where we're up to approximately right now. She's just completed that, I believe.
That's right, Susie, you have a comment there, and she's your patient as well.
Sorry, yeah,
You've been very
my
busy
hand up
today.
yeah, she's finished her chemo. She hasn't had the brachy yet, but that's coming up.
Yeah.
I think, have I stopped sharing? No, am I?
You have stopped
Yep.
sharing. Yes. Yeah. Thank you. So I think the significant thing about this patient is the colitis. That I agree. I think not having a colitis, I think you would have thought about it differently, treated the cervix differently. So I'm going to take questions with those who have hands raised. So Siddharth, you've got your hand up as well.
Yes, just as a query regarding brachytherapy. What dose and how are you going to treat that? Just the cylinder or something else? 3 fractions, 4 fractions, 6 fractions, margins positive.
So she is going to have. Shall I leave you to answer that, Susie? As in, because I think what we're going to do is we're going to examine her and probably do a day 0 MRI scan just to double check if she hasn't got any disease left in that area. I mean, we as far as we know, there isn't any disease there, so it's possible to do an MRI scan. I don't think that we've examined her yet after her
No, she literally, I think,
yeah,
as in, like a few days ago, she had her last chemo.
Yeah.
I don't think we've 100% decided that yet about
No,
dose.
no.
Yeah.
Yeah. Open to you to say about the doses. What would you think about the doses? Because I think it all lies to what is the residual disease. Is there residual disease on the MRI scan? Would you be thinking about a radical brachy dose by itself? And in that case, you can be up to from 4 to 6 cycles, depending on your MRI planned, because then you would have to treat that as a GTV and a high-risk CTV. If it isn't, I mean, it can be treated as an adjuvant treatment, but then you have to make sure that you're covering with margins, and therefore it's not a standard volt brachytherapy, depending on where that lesion was.
Yeah, it's always tricky post-op, isn't it? Where the margin is and how it dishes. And sometimes you may have to think whether to give mini pelvis, just treat external beam, which will give better coverage than brachytherapy. Because it depends upon what you see on MR, how that ear tags go outside, where you can cover that with the brachytherapy. Rabbit ears just go laterally, and then you can't cover it adequately. Sometimes that's the issue.
Sorry, I've missed that. What did you say?
So you sometimes get these tags of tissue going laterally from the vault, and you can't cover that one with the vault brachytherapy usually. And if you're worried about it, that could be the margin, whether to give external beam radiation, just mini pelvis.
I think you mean as in the vaginal vault. The vagina is not snug on the cylinder.
Yeah.
I think in that case we have got different devices that we use. So you can use colpostats. You can, as in just colpostats. You can use, if there is the residual disease, you can use interstitial. But that's the reason we do a day 0 MRI is basically just putting what you would think that you're going to be using, and then checking whether that would be covered all right with the applicator or not, because you'll be planning it rather than just giving a standard dose. But with the applicator in, and you can see where the tumor is, where is your applicator? Are you happy to use it without theatre? Isn't that going to be a multi-channel cylinder rather than a standard cylinder? It all depends on what she's like after the chemotherapy.
Agree. Yeah. I think if the disease is there, then it's a bit easy. If there's no disease, then it's a bit more tricky, isn't it? Sometimes.
Exactly, but I think you'd have to plan it either way, because you need to give sufficient margin around it. It's not like a standard adjuvant endometrial, post-surgical endometrial. And this is what we would do normally with patients that have residual disease. So we tend to bring them in a day that we're not going to be treating them, put the applicator in, that ideally this is what they would be treated with as an outpatient, do an MRI scan, send them home, and then decide whether they're going to be straightforward with even if it was a planned multi-channel, we document the position of the cylinder, the pitch, how high it is, the distance and everything, take photographs, because this is how we would be using it. Yeah, but otherwise we can use interstitial or a different type of applicator. Alex.
So I just think it would be good to get other views as well, because I suppose the question is, should she have had the uterus removed at all? You didn't give us that option in the poll. And I must say, I think what this has highlighted is why we give definitive radiotherapy for stage 2B disease, because even after 6 cycles of chemo and BEV, this patient still had extensive disease. And it shows that, I know there's all this belief on giving chemo, but actually it's why we don't do rad-his on stage 2B disease, because it's sort of more advanced. So I have to say, when I've had concurrent, we'd often do the BSO and the omentectomy, but leave the uterus in place and give radical radiotherapy.
I think we had a very long discussion about her in the
But I'm just conscious of other views as well. So
yeah, no, absolutely. But you can imagine how difficult this was as a discussion
sure.
between the surgeons.
I'm just thinking in general, Hodder. So
yeah, absolutely. Yeah. Louise.
Actually, very similar point, to be honest. I was wondering, had you considered giving radical radiotherapy for the cervix cancer and doing, I think it was fallopian tube cancer, wasn't it? So maybe doing a BSO, or even just radical radiotherapy to the pelvis and surgery to the upper abdomen. I was just wondering what your discussions involved and your rationale for doing what you did. But really interesting case.
Yeah, I think we did have all of these discussions, and I think this is what the surgeons felt.
I think it was more geared by the surgeons, to be honest, at that point. And I think it was more influenced by how the disease looked on imaging, if I from memory, that it was very limited to the cervix, as in a small cervical tumor, which looked as if it could be as if you can deal with it as it's a 1B. I mean, it might turn up that it's a 1B. Obviously, that's not the case when it was.
There was also quite a lot of discussion about timing, because obviously she's also undergoing systemic chemotherapy for the fallopian tube cancer, and so when would you do that radical radiotherapy was another question in our MDT.
Any other comments or any? I can't see the chat. I'll just have a look.
So there's a comment from Kate about the prognosis from the serous cancer, and I guess that ties in a bit to what you were saying, Susie, about which of the two is the high risk, and with the systemic treatment, when do you fit in the radiotherapy part? I don't know if you had a feel for which of the two was the more aggressive.
I think it was the high-grade serous.
Yeah, I agree. I mean, that was obviously more advanced, and
yeah.
It's
an unusual and very unlucky, actually. I think, don't think we imagined that it's not the same disease. As Robin said, she was staged and then restaged again to change the, But thank you very much, Robin, for presenting it. And does anyone else have any other questions before Alex give us a... do you have slides, Alex, do you?
Yeah, I've just got a couple of slides. I mean, this is really, let me just share. Is that sharing okay? I mean, this is not that I'm giving a talk on the topic. I'm just running through a couple of slides just to make sure everyone is aware that there is now compassionate access available for tisotumab vedotin for second-line plus treatment of cervical cancer. And it was really to sort of we try and use these meetings to prompt awareness of things sometimes, just because the companies have released this, but you have to approach them for them to tell you about it. So it was just really to say that it's available. I've swiped a couple of their slides, just a quick reminder. And again, it may be worth us having a debate about whether you'd use it at all, because it's been a long time coming. As we know, this trial was actually published about 3 years ago. And then the company went very quiet, and TV has only been available in the States, and they didn't really take it forward, but it is now licensed in Europe. It is not yet licensed in the UK, and therefore currently it's for NHS patients through compassionate access is the only route that you can get this. And the company will provide it for free. And basically it's on the basis of the Innova TB301 trial, which was for second-line plus recurrent metastatic cervical cancer. And it was randomization of TV versus investigators' choice of single agent chemotherapy, which did not include weekly Taxol. It's the usual sort of drugs that they used. And really this is just to remind you, this is the primary endpoint that we can see for overall survival. So there was a significant survival benefit. Median survival increased 9.5 to 11.5 months against investigators' choice. And similarly, you see the benefit in progression-free survival, but the curves do come together. We can see it's not a huge benefit in PFS between the two arms. And again, at 6 months there's a benefit, but the curves are really coming together. Your numbers are tiny once you hit 12 months. And it's also just to highlight, because this is what, if any of you are going to go through the route of the compassionate access, is the company will do, these are the slides that I've sort of screenshotted, but just to highlight the adverse events. So this is the comparison of chemo to TV toxicities, and across the board adverse events are similar, but just sort of highlighted here in green are the particular ones with TV. And in particular, you'll see it's conjunctivitis, peripheral neuropathy, keratitis, and some epistaxis. So different toxicities. These ADCs, as we know, have different toxicities to what we're used to, whereas your chemo, it was just hematological. Again, I'm not going to go through all of this, but it's just underlining that the ocular events that occurred, and it's a high incidence of ocular toxicity, generally occurred, median kick-in was early, within the first couple of cycles, but by withholding and dose reducing, there's mitigation and it improves. And this is just the summary, because again, if any of you do this, patients are required to have an eye exam prior to starting the drug. So you need to have ophthalmic review prior to starting. And there's a whole regimen of the drugs in terms of mitigation, in terms of eye drops that they need to be given prior to, during, and after the infusion, as well as cooling baths whilst you're doing the infusion. So there's mitigation that does improve the toxicity. And again, it's just a reminder here of that for each cycle, it is expected that there will be assessment of the toxicities. And again, they've got very good slides to tell us what to look for, but you need to have pathways in place for management of the patients with ocular toxicity. So it was just if there's comments, but it was to sort of highlight. I think I've stopped sharing.
That's interesting. I mean, they don't say, I mean, they say that you'd have eye examination before, but is there a contraindication for patients with certain issues about eye health that shouldn't be offered this treatment?
I think if there's pre-existing sort of keratitis, then
you'd assume so, but it's not sort of, yeah. Okay. So we've got a couple of questions. Kate, you've got your hand up.
Hi there. Yes, thanks. I wanted to ask about this. Is it definitely just for second line, or can they have it third line?
It's second plus.
Yeah. And can it be? There's a debate about histology. it was originally reported as clear cell, but I think they've come down as a sort of more mucinous adenocarcinoma. It was definitely cervix though.
I think that's right. It's an adenocarcinoma.
Okay.
So
still,
it's pretty permissive, I think. So yes, it's any line beyond first, if
Okay,
they're sort of that it can be used. And yeah, I think they're just keen for people to have access to it and to go through it. So it is available, but I mean, we all have to set it up and have the pathways in place. I'm not sure. I'm not utterly convinced but it's an option for patients that we have.
Which is
it sits in the
patients that we
same
don't
level
have.
that cemiplimab will be for some patients if and when that comes through.
Yeah, lovely. Yeah, I mean, it's interesting how permissive they are. I mean, it's, you know, Pembro, Bev, anything that they've had, it's all, you know, it's okay. Asma.
Question, Alex. Have you accessed this? Like, how long is the wait to get it? Is it quite a wait? And do you have any contact details for who we would contact as well?
Yeah, I mean, I can share. I mean, it'll be the local sort of GenMab rep. I can sort of, yeah, I did ask them because obviously you have to approach them. We pre-registered and it's just working through. So I haven't treated anyone on the scheme yet. I think someone has. But they are sort of, you obviously have to take it through pharmacy, etc., etc. So I think we are signed off in about 2 weeks' time. But I think in terms of the turnaround from the company's point of view, it's pretty quick. You have to do the training on the ocular toxicity and link in. Yeah, they're very happy to be approached. I think they were having the question on whether it should be open to everyone or centres that are comfortable with managing the ocular toxicity. So I think that's why it's being highlighted.
Yeah, and I guess you have to get the ophthalmologists in as well, accepting to, because that's another. I mean,
think
we
most
have
centres
got
are starting
our
that because of
hospital in.
mirvetuximab as well has got the same requirement. So we're sort of tagging on the back of the pathway they've already set up for ovarian cancer and linking it in for this. So I think, yeah.
And Lindsay Phelps, you've got your hand up.
Hi, yeah, thank you. Just wanted to say that we had a patient in Exeter who we'd actually applied through the drug company and gone through all the training, and was very hopeful, and it was looking promising. But unfortunately, we've had the red light from pharmacy and capacity trust issues. I was just, very interested to hear if anyone is being able to offer it on the compassionate use and whether we'd be able to. I know we're down in the southwest, but patient is very willing to travel. Just wanted to ask if there were any other centres that had it open and were able to give it. Thank you.
I mean,
I guess that's only you, Alex, around here.
I know. I mean, this was the issue previously with compassionate access schemes. As we know, different hospitals, sometimes pharmacy can take a long time to set up protocols. And I think we certainly previously took patients through the compassionate access to try and help. The trusts will get a bit challenged if we are taking on too many. So I know from the ovarian side, out of area compassionate access is not being taken on routinely. But I think for cervical cancer, we have such small numbers, we should be helping each other out.
Thank you.
Thank you. Right, if there are no more questions, I think we're nearly 7 o'clock, and I'm really impressed to still have 40 on the line, which is great. Thank you so much, everyone, for staying and for this very active participation in this forum. Thank you very much for the committee, and thank you, Susie and Robin, for presenting today. So lovely. And please keep an eye on the feedback forms in order to be able to get the attendance, and keep an eye on the announcement for our next forum, okay, which should be in about 4 months. Will date to be agreed. Thank you very much, and have a very good evening to all of you. Okay, bye-bye.
Thank you.
Thank you. Thank you all.
Thank you.
Thanks.